Who have we got here?
I am.
Hello.
Good morning.
Good morning. I'm sorry, my mouse battery on my computer's gone flat.
Morning.
Oh, that's annoying.
I'm like trying to open Zoom, but I've got to charge it. So I've just opened it on my iPad, but I'll switch over to my computer and share screen once it's got a little bit of charge in it. Hi Pooja, how are you?
Morning. How are you? Good, thank you.
Morning. So the first thing I wanted to do today is actually just go through the subjects that, or the kind of body systems that have already been covered in the membership exam.
Oh, sure. Yeah.
Do you have that off the top of your head, do you reckon?
Yes. Paper one was calcium homeostasis.
Mm-hmm.
The autonomic nervous system regulation of blood pressure.
Oh, okay.
Leptospirosis.
Yeah.
And let me come back to that. Paper two was a cat with that presented for uveitis that had systemic crypto, an insulinoma, a fate cat, and laryngeal paralysis.
Oh, that's right.
The other one on paper one was myasthenia gravis.
Oh, great. Okay. So in terms of like when you're developing an exam, you essentially write down all of the body systems that you need to examine, and then you do a blueprint and you kind of go, okay, well, I've done, so calcium homeostasis is probably endocrine.
Yep.
BP is probably cardiovascular / neuro if it was nervous system control. And then the fate cat was probably cardiovascular too, right?
Yeah, there was a bit about like working it up afterwards and things. Yeah.
LAPA is your respiratory system. Insulinoma is another endo. Uveitis, systemic inflammatory disease, infectious. And lepto is infectious, and then myasthenia gravis is neuro / does it have anything about like pathogenesis, like
yeah, it was about that. It was the etiopathogenesis and what essentially like why, because it was in the pathophys paper one. It wasn't about treatment, it was like why that leads to the clinical signs.
Oh yeah, okay, right.
Yeah,
so it's quite like neuroanatomy, like NMJ sort of physiology stuff. Okay, so that we're going to call that probably neuro rather than like inflammatory disease, like they weren't talking about the autoimmunity.
No.
Yeah,
like not treatment anyway.
Okay, so what are we missing? So we're probably not going to get another endocrine question. You could get another respiratory question just because LAPA is such a small area of respiratory, so we might get another respiratory. You're probably not going to get another cardiovascular, which is interesting because I find that so much easier to examine in oral setting because you can do like ECGs and X-rays. And stuff. But that's fine. I doubt you're going to get another infectious disease either. So we haven't covered GIT or hepatobiliary kind of disease.
Yeah, there was really nothing on liver at all.
Okay. And then they could do another neuro, but I doubt they will. It's not like a big area. What other body systems do I have? Let me open up my...
Renal?
Renal, yeah.
Renal.
Genitourinary. That's a big one. That's a big hole in there. Okay, cool. And we don't have the previous oral exams or anything, do we? Like
I can recall when I sat I'm trying to, because somebody the other day asked me again, what did you have? And I was like, oh, it's like I can't remember exactly, but I can try and pull up from my brains when I thought what questions they were for oral.
Yeah.
I think there was something on diabetes, I think.
Yeah.
And then one was I think it was a crypto case or a toxo case in a cat. So infectious.
Well, mine were infectious and respiratory and cardiovascular, pretty much. But they do like to show blood tests and get you to like talk about, you know, what the picture is, kind of thing. And I guess like I can see why that's easier sometimes to examine verbally than it is like written. What else have we got? 2016. Gastro, genitourinary, immunology. Onco. Haven't done much onco.
That's a good point. I didn't even think. Yeah.
So onco is kind of a nice one as well, because like I could make a genitourinary question where it unfolds that there's a TCC, for example.
Yeah.
Or something like that. Yes, it could be in another body system.
There also wasn't, there is a few in past papers, so I guess they want to mix things up, but there wasn't like a IMHA, IMTP, IMPA, SRMA, anything like that.
Yeah, that's why I was
immune mediated.
Yeah, that's why I was asking what the angle was on the myasthenia question. So I think that could easily come up. So for example, if I was like doing this blueprint, like where my brain goes as far as kind of clin path and immunology that we haven't really covered, I would probably show up a CBC and ask you to like review it. So say it was an IMHA case, what would you see on your CBC that would make you confident of your diagnosis? What are the criteria for making a diagnosis of IMHA?
So firstly, you want to document that there's an anemia, which typically is going to be moderate to marked, and depending on when they present is likely to be regenerative. So you'd want to look at your red blood cell count and then your reticulocyte count, which should be above reference range. Because you've got increased reticulocytes, you might have increased cell volumes. Your MCV might be increased. And you're also going to want to document that you have got evidence of immune-mediated destruction. So I suppose that's not on a CBC. Is a blood smear included in that?
Yes. Yeah. There's a smear review by pathologist. Yeah.
Evidence of, especially in dogs, of spherocytes or of ghost cells, both which indicate red blood cells have like had a chunk taken out of them and then reformed. In what else would you maybe see? And you'd also see like anisocytosis, so smaller cells and then much larger cells with your reticulocytes on a blood smear. Yeah,
cool.
They're probably your markers of immune-mediated disease, and then you want a marker of hemolysis, so like either hyperbilirubinemia or you might want to look at urine if you've got intravascular hemolysis. I guess you might not have really high bilirubin.
Yeah, good. Okay, I'm just going to switch computers. Oh, I'm back. Better. Okay, sorry, get my notes up. Okay, good. So that's essentially the criteria for making a diagnosis of IMHA. So if you do, like, if there is an anemia hematology flashed up in front of you, they will either give you enough information or want you to say there's not enough information here for me to confirm a diagnosis. So what I'm missing out of this is evidence of hemolysis. I would be looking at bilirubin, and other markers on a biochem if that was provided, and then they'll probably give you the next thing. Or they will like very clearly give you enough to make a diagnosis. So you might get the CBC and then you might get just the liver values or something like that on your biochem. So just they don't give you superfluous information in an oral, so everything is relevant, and they're either checking what is missing and want you to ask for that extra bit of information, or they are wanting you to like probably say like this is my diagnosis or this is my assessment, and be quite specific about it. If they give you a full panel in the first section of the question, then they're probably testing your ability to cast a wide net and do like prioritize differential lists based on that. So it might be that if there's not enough information, you can say, well, I think this is my leading diagnosis here, but I can't actually make that diagnosis, and I will also have blood loss hemolysis from other causes and decreased red cell production on my list, although that would be atypical with regenerative anemia, something like that. Cool. So I think that's like, from the profile that you've like painted, if I was blueprinting an exam, I think that's a really easy topic to examine on. And ITP is so clear cut, like it's so easy to diagnose. I just think it's not like they might test your primary coagulopathy knowledge or like disorder of primary hemostasis knowledge. And give you a case that's presented. So if we want to run through one, there's a 4-year-old female neutered catalogue cross who's presented with bleeding gums and scleral hemorrhage. Give me a prioritized differential list for potential causes of this dog's clinical signs.
Shall I go?
It's already sat. It's all you today, Helen.
Mucous membrane bleeding is really consistent with a primary coagulopathy. So the first thing I would do would be, not to do a differential list. Thrombocytopenia would be by far the most common, whether that's immune-mediated destruction, consumption, or consumption, or lack of production, which is so rare. Thrombocytopenia, which is incredibly rare, or von Willebrand's disease, which is usually congenital, like acquired, very rare, which would be unusual for a 4-year-old dog to present for the first time with von Willebrand's, especially a young to middle-aged female dog. It's like very IMTP.
Good. Anything else?
Primary. Like, don't they get that with severe erythrocytosis? You can get mucous membrane bleeding.
Yeah, actually, that's a good point. Yeah.
So,
vasculitis?
Pardon?
Did you say vasculitis?
No, I didn't. No, that's a great one.
So that's the 3 for like mucous membrane bleeding, platelet number or function disorders, vessel wall disorders.
Vasculitis. Yeah.
Sorry, it jumped in. I just was like, I got distracted because my son's coughing and I just need to go and tell him to take his puffer.
How was your exam? What did you feel?
It was okay. It could have been worse. Could have been better. I really didn't love the laryngeal paralysis question. I wrote such a waffly answer for that. I hadn't actually studied it, which is my bad. I just thought that was so surgical.
I think your knowledge is pretty sound. I think don't worry, just sit and it's a good feeling to not be super confident. I think just wait and watch, see what happens.
Yeah, and I
Focus on
think
the oral.
You never really come out of an exam like that was amazing, do you? Ever?
You shouldn't because if you've done that, then you've maybe fucked up.
Yeah, that's true. Like I felt really terrible after that. I'm like, well, I felt terrible after every exam in vet school, you know. I don't know, it could have been worse. Some of them I thought were quite fair. Like you heard the topics, you know. Some of them I was like, yeah, this is fair, even though it's hard. I don't know. It's really hard. It's really hard to know. Yeah, I'm trying not to spiral about it, like you're saying, just focus on your oral.
Yeah.
How did you find the oral?
For me?
Yeah.
Oh, okay. So because I think I was a bit overconfident because I love case discussions and I'm somebody who's extremely loud and talk anyways. So I thought, oh, it's not going to be a problem. I mean, knowledge-wise maybe, but not in terms of, because people had told me, oh, you freeze and that sort of a thing. So I thought that's not going to happen to me because I'm used to talking. But honestly speaking, I experienced that. So yeah, you do. I didn't necessarily freeze, but every now and then it took me a lot longer to answer because in my head, not so much in this thing, but I think yeah, be mindful that yeah, you may freeze. So practicing is a good idea, which Anna obviously does with us. Uh, I think yeah, I would say don't be overconfident. Just sort of answer, keep cool. If you think you don't know, just sort of close your eyes, take a deep breath, because it'll just come. You just don't have to, they'll give you nothing. So the examiners will give you absolutely nothing. And I think that was a big thing for me because I am so used to people like looking at you and sort of, you'll read body language, whereas these guys give you absolutely nothing. So it's like, have I said everything? Are you're just staring at me? Should I be saying more? Should I shut up now? Like that sort of a thing.
That is super awkward. And I guess that, like, if we really kind of look at brain function, if you're in fight or flight mode, you can't use your cortex. You're just all in your like limbic system, amygdala, like you're just getting out of the situation, right? So you're going to give waffly answers, just just to try and get out of there.
Yeah.
That like taking a pause, closing your eyes, taking a breath, doing some visualization that just really brings you back to the present and gets you out of that like fight or flight, because they'll throw a question at you, you won't know the answer, and you'll go full like primal brain. And then you'll start spinning if you don't have those strategies in place to like get back into here where we need to be. Okay, so what we're supposed to be talking about today is nutritional management of metabolic diseases, including hyperlipidemia. Something that wasn't on the list is hepatobiliary disease. Just to try and like reference at least the topic we're supposed to be talking about, we could maybe make up some questions about that. Let me just have a quick look at my list. Okay, let's do a liver case, and throw some nutritional management into it there.
Okay.
A 7-year-old female neutered cat presents to you with a 5-day history of anorexia, acute onset anorexia, intermittent vomiting, and progressive lethargy over the 5 days. On the blood tests, there is profound elevations of ALT, mild elevations of ALP, no elevation of GGT, and AST is profoundly elevated as well. Bilirubin is moderately elevated, 50. ALT, AST very high, bilirubin and and ALP moderately high, and then normal GGT. Based on this history, give me a prioritized list of differentials for this cat's presentation.
And Anna, I'm so sorry. A call came through, so it muted you just at the first bit. What was the signal?
So I think it was a 7-year-old female neutered cat.
7-year-old.
Yeah. 5-day history of anorexia, acute onset anorexia with intermittent vomiting over that 5 days and progressive lethargy.
Okay. And any physical exam findings yet? No,
Or
okay.
normal, or normal, like dehydration, but otherwise.
Okay. So my differential diagnoses would be in sort of semi-order of importance, a cholangitis, either a neutrophilic cholangitis or a lymphocytic plasmacytic cholangitis or cholangiohepatitis, because there might be hepatocellular damage there. At 7, I would have lymphoma on the list.
Good.
A infectious disease, so it's not quite necessarily the right signalment, but I would have things like FIP and toxo on the list as infectious disease.
Right.
Other types of neoplasia would be uncommon at that signalment, but like a biliary duct neoplasia would also have to be on the list for a post-hepatic cause.
So tell me where, like, sort of prioritizing. You mentioned kind of cholangitis, and then you mentioned a hepatocellular or primary hepatic, and then you mentioned a biliary, and then you went back to a primary hepatic. Based on the blood picture, do you have a feeling of like this looks more like a hepatocellular or a biliary disease? And there's no right answer, but
I just feel like cats do whatever they want with
that's a good point.
Like I would say like with really marked ALT and AST elevations, you'd expect like a significant amount of hepatocellular damage, so potentially something that is primary affecting. But then also I feel like cats get that with when they've got more like diagnosed cholangitis, so technically shouldn't pass the end plate into the hepatocytes, but their liver enzymes are still massive.
Yeah, and the ALT is often much higher than the ALP because the ALP's got such a short half-life in cats.
Yeah, and they don't make a lot of it, I guess. Yeah, so there has to be some biliary involvement for a cat to have a moderate elevation of ALP.
Yes,
not just primary hepatic.
Yes, except that when you get primary hepatic disease, those little canaliculi get blocked.
Of course, yeah. That's why you've got intrahepatic hyperbilirubinemia. Yeah.
Yeah. So, the one giveaway there was the GGT.
By being normal.
Yeah. And you're exactly right. We've seen cats with profound cholangitis with normal ALP levels. Like their biliary enzymes are not predictive of what's going on in their biliary system. So cholangitis is the most common thing. But I would like in your answer for you to say, technically, this looks like a primary hepatocellular disorder on paper, but I'd like to acknowledge that we've seen a lot of cats with neutrophilic cholangitis in particular who have quite normal biliary enzymes but very elevated ALT, so that would also remain on my list. And then talk about the hepatocellular disorders and biliary disorders almost separately.
Okay.
Just to show that kind of understanding of like these are the biliary enzymes, these are the primary hepatic enzymes, and there's blurriness between them, but like that ratio is kind of a nice thing to demonstrate your understanding of.
Okay.
So then further you've got there's one more differential. We just don't see it in Australia, but it's a nice one to examine.
Hepatic lipidosis, yeah, of course. Especially with a normal GGT and a high ALP. Yes,
yeah, exactly. So chuck that on the list as well. It's often not the primary, like they were all with something else, but
yeah.
And they might be diabetic or whatever, So then, what further testing would you like to do in this patient?
Has it had a CBC yet? Did you say? I'm so sorry. Yeah. So I'd probably do the rest of that if it hasn't been done, like a CBC, FIV, FELV.
Yeah.
And I'd examine a blood smear. And I think probably the most important next diagnostic test would be an abdominal ultrasound. It's going to help us to assess especially our post-hepatic causes of hyperbilirubinemia and that biliary system really well. It might give us an indication about primary hepatic disease, or maybe normal. It would also give us the opportunity to do sampling if we wanted to.
Right. Okay. Talk me through the process of taking samples from a liver, the precautions you would take, and the process of taking samples from a cat liver.
So if you had a cat that has either evidence of marked hepatocellular damage or marked cholestatic liver disease, they may have a coagulopathy. So you may want to pre-treat with vitamin K or run coagulation testing and check your platelets. Cats, even with coagulation testing, aren't that reliable. You can have cats that bleed even with normal coags after liver sampling. So if you've got really severe disease, pre-treating with vitamin K is, I think, a reasonable thing to do. You would want your patient very still, so either sedated or anesthetized, depending on if you are sampling with a fine needle aspirate or a true cut, which is much higher risk in cats. If you were doing true cut biopsies, I would sedate the patients that are really still. Use ultrasound guidance so that you can target the specific area of the hepatic parenchyma that you want to take. I'd use a 23 gauge needle attached to a 3 ml syringe, and under ultrasound guidance, I wouldn't aspirate. I would just sort of gently poke. I don't know how to explain that in an exam.
Woodpecker technique.
Yeah, woodpecker technique, sort of gently. Prepare my slides, and then I'd keep the patient hospitalized for probably up to 4 hours post-procedure, and just scan 30 minutes later and then 60 minutes later to look for free fluid, and have the patient monitored well as it's coming round for bleeding. That's probably going to be the biggest risk for sampling. Yeah. If the other sampling that cat might benefit from, depending on the results of the ultrasound, would be a biocentesis for culture, which again, you prepare the patient in the same way, potentially under light anesthesia, so they're very still, and approach the gallbladder through the hepatic parenchyma and drain the gallbladder completely, so the parenchyma then can seal over that gallbladder. The risks are hemorrhage as well, but also if you have got a bacterial cholangitis, you could end up with a bile peritonitis or a septic peritonitis afterwards, which can require to be surgically addressed.
Are there any contraindications for cholecystocentesis?
A coagulopathy. If the gallbladder wall looks not intact, or incredibly, I'm not sure there's a scientific way to say this, but if your gallbladder wall looks incredibly edematous and really angry looking on ultrasound, I think there'd be an argument that you might have an increased risk of gallbladder rupture in the procedure.
What else would be a risk of rupture?
If
it's under more pressure.
Oh, if you're worried about a complete obstruction.
Yeah, exactly. Yeah. So I don't think you'd ever get that question in a oral exam, but they do tend to quiz you on techniques a little bit more than they would in a written exam. So what stain would you use, and what test would you send it off for, and how would you obtain the sample? And it would be very reasonable to say, I'd never going to do a cholecystocentesis in my practice, but I would potentially refer for cholecystocentesis and rely on a specialist, somebody who's experienced in that too. Although I want you to do them. Good, excellent. Okay, so this cat had hepatic aspirates done. I kind of think I asked you this a couple of weeks ago, but came back as hepatic lipidosis.
Okay.
Can you run through your nutritional management of hepatic lipidosis?
Yeah, we did that a couple of weeks ago.
Don't worry about it then. You've done it.
Are you sure?
Comfortable answering that?
Mm-hmm.
Yeah. But yeah, I think you nailed that answer last time. So
And I'm
what?
going to start driving, but I'm still I'm
Okay.
still here. I'm just going to start
Oh, I
driving.
don't want to distract you.
No, you're fine. I can still
Okay, let's talk about hyperlipidemia. Are you following the rules of the law, Helen Todd?
no, my silly little thing's not working, so I might have to have you on the seat next to me, but I can hear you. I'm sorry.
Get to work, Helen.
I know. I can hear you.
So, while we're talking about lipidosis and on that kind of vein of like nutritional management of hepatic disease, or metabolic disease, how about we talk about nutritional management of hyperlipidemia in dogs?
Okay. Yeah.
Pooja, do you want to, if I sort of said a 10-year-old Schnauzer presents with intermittent dullness, gastrointestinal signs, and a mild proteinuria, which is reported with hyperlipidemia, and a triglyceride of 25. Discuss your initial approach to management of this patient.
So the first thing, I mean, Schnauzers is a breed that is predisposed to primary hyperlipidemia, but I still would want to confirm whether this is a fasted sample. Would that be accurate to see?
Right.
Though 25 is pretty up there, so but I would still want to confirm it's a fasted sample, at least 12 to 14 hours of fasting.
Yeah, great.
And then in terms of like if we confirm that yes, it's a fasted sample and this is true, then I guess in terms of nutritional management, first thing would be to what I do is just low fat diet, GIT diet, and see what that does. I don't know how long one should wait to see response in the sense like, do you put them on 3 or 4 weeks, and if no response, then put them on some drugs? I don't know that bit. Like, how long should you wait to see a response?
I actually don't know either, to be honest. I think it should be quite short term. If they're obese, it's going to take longer for that triglyceride level to come down. So how long I'd wait to repeat bloods will probably depend how fat they are and how much weight I want them to lose. So I might, if it's a really obese dog, I might say, okay, I want you to come in for weigh-ins every 2 weeks, and we're going to repeat the bloods in 6 weeks, to see what response we've got. Because the other thing about hyperlipidemia is it's not an acute disease, right? It's been around for a very long time. The effects are very long standing. It's not like we have to get a result and be really on it like we would an infection or something. Whereas if they're quite lean already, I don't want them to lose too much weight. I know that when we don't have, with that weight loss, increasing circulating triglycerides. So I'm going to get them in earlier, reweigh them in 2 to 4 weeks, probably, depending on the owner's keenness to get on top of it. So ultra low fat diet, number 1 strategy. Number 2 strategy, if that fails.
Then you put them on drugs, like phenobate.
Is there anything?
But the question is, because we know that Schnauzer is a breed that has primary hyperlipidemia, how much do you investigate for secondary? Because you shouldn't be calling something primary unless you've like excluded secondary causes. So how much do you go hunting for endocrine diseases to be a result of this?
Which endocrine?
Like in a breed that's predisposed.
Yeah, it's tricky because most endocrine diseases will cause a hypercholesterolemia, but not a hypertriglyceridemia. And if it is an endocrine disease, it's usually the hypertriglyceridemia might be there because of, like, for example, Cushing's. Cortisol is going to mobilize more fat. But it's going to be pretty mild because those triglycerides should be processed and excreted or stored. Basically, they shouldn't just be floating around. So, yeah, I would probably say we should probably do, if there's clinical signs present, I would do testing for hypothyroidism and Cushing's disease. But if there's no clinical signs, and breed consistent with familial disease, then I would probably just treat them.
Yeah.
And again, the endocrinopathies we're looking for aren't acute onset. They're slow, and you can treat the hypertriglyceridemia. And if you're not getting anywhere, then you can test.
Yeah.
Good. There's one supplement which we should include in our nutritional management.
Is it fiber?
Omega-3s.
Omega-3s.
Omega-3.
Yes. Yeah. So most of the time, high dose omega-3s will result in at least a 50% reduction of triglyceride levels, which is our goal of endpoint of therapy. So that's kind of a really effective non-pharmaceutical option for the owners. And often I'll start that at the same time as the diet because I don't really need to differentiate what's like causing the positive effect between diet and fish oil. Like that, they can have both, that's fine. Whereas when I'm starting a medication, I often sort of think, okay, well, if we get a side effect and I've started diet, medication, and fish oil at the same time, I'm not going to know what the side effect's from. Whereas diet and fish oil, I think we could probably start them together. But very effective treatment. And there's licensed doses, like for specifically for hypertriglyceridemia, as opposed to like osteoarthritis and stuff like that. So have a look at the doses. If you can just Google it, and AI will tell you now what they are.
AI gives half information wrong, so I don't really like AI.
It gives a lot of information right though.
Okay, have you ever come across a dog that has a chronic enteropathy, so food responsive chronic enteropathy and hypertriglyceridemia? Is that something that happens, or is it just
Yeah, for sure. Hypertriglyceridemia is one of the least, like, it's a really big problem over like chronic when the dogs are chronically hypertriglyceridemic, but we don't focus on it as a clinical problem, mostly because it's not even on most IDEX panels, so it goes so
Mm.
underdetected. But yeah, I think it's a
But then
big.
how would you manage that then? Because like hypoallergenic diet is so high in fat.
Oh yeah, that's tricky.
Then that gets tricky, right? Like what would you prioritize then?
So I would say most of the dogs that I've seen with clinical hypertriglyceridemia have intermittent gastrointestinal signs. So I'd probably actually prioritize. I'd probably try and get on top of the gut with medications, fecal transplants, and other kind of means, and try a low-fat diet with fish oil and see how the gut signs go. How often are they having diarrhea?
Oh, this is just like something that came up to in my head right now.
Oh, okay, right. It's not actually
Not actually a case. I was just wondering if something like that happens, and if it did, then how do you manage this sort of because it's like a comorbidity and they're very opposing diets. So what do you prioritize?
Yeah, tricky.
Refer to a medicine specialist.
Thanks, Mom.
Anna, do you ever have to manage the proteinuria associated with hypertriglyceridemia? Does that tend to resolve with management of the hypertriglyceridemia well, or do you ever have to manage that as an entity in its own right, or does it depend on the magnitude?
It depends on the magnitude. So typically it's quite low grade with hypertriglyceridemia. I feel like schnauzers need their own UPCR reference ranges, but yeah,
Okay.
I would always try and manage the hypertriglyceridemia and then work on the proteinuria if it failed to go away when we got on top of the triglyceride level.
And you know how patients with really low albumins, if they've got a severe protein losing nephropathy, that in itself can upregulate your triglyceride production. Would the problem of the PLN predominate the clinical picture so you know which way round it occurred?
Yeah, so you're never going to get a hypertriglyceridemia causing a UPCR above about 4, whereas a protein losing nephropathy severe enough to cause a hypoalbuminemia, the UPCR is going to be massive. It's going to be like 8+.
It's going to be huge.
And it's just that,
okay, that makes sense.
It's just that kind of scale of elevation. We actually had a cat with that looked like it might have a protein losing nephropathy the other day that we scanned. Had we sort of, the kidneys looked abnormal, but and had an albumin of 15. And we took some urine, and there was 3+ on the dipstick, so just waiting on the UPCR results.
9.
Interesting. 9? What?
It's going to be 9.
I'm hoping. I mean, not for the cat, but I don't think I've ever seen a cat with really severe primary, like glomerulopathy. Is that right?
Yeah. Yeah.
Have I-
Yeah.
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 I had a
And so-
case of a Maine Coon a few years, 2 years ago. Can't remember the exact details, but it was a young cat, like 9 months. So actually had peripheral edema as well. So initial
Ooh,
thought was maybe FIP because like, the signal
yeah.
meant pure breed cat, hypoalbuminemic. But then thankfully did UPC and the UPC came back as 9 and was like, wow,
Oh,
this is glomerular nephropathy. Just
yeah.
what
It could
kind?
be FIP and glomerulonephropathy because isn't it's antibody antigen complex deposition often that causes the glomerulonephritis in cats? But
Yeah.
so often they've got systemic inflammatory disease. Or other differential would be systemic colici.
Hmm.
An interesting one. That puffiness was like quite a distinctive feature because of the degree of vasculitis they get. Yeah, we had a little outbreak of systemic colici in Sydney a few years back, and they all had puffy feet.
Hmm.
Hi, Julian. Sorry, came in mid-conversation.
Sorry, I came in late this morning.
He's fine. It's Friday morning. I did too, actually, for the record. My mouse battery died. I was like, I actually can't open Zoom.
I don't know the keyboard shortcuts.
I know. I was like tabbing and stuff. I was like, how am I going to get in? Anyway, okay. So we what we did earlier on in the session is just go through what's already been examined in the membership exams, and then like talk about the blueprinting exam process and what's left to be examined. So what we came up with is immunology is a big one. They love showing up like blood test results and stuff. So we've just gone through IMHA, IMTP, and some hepatobiliary stuff that hadn't been covered yet. Onco, I think, is a big one. So I would, if I was going to write you a question, based on the topics that haven't been covered yet, I would give you an obstructed dog with urinary obstruction, a dog that's presented straining to urinate. There's a large firm bladder on palpation. Describe your approach to further testing for this patient. Oh, Helen's in a black hole.
So I would, no, it's okay. It's really jumpy, but hopefully you can hear me.
Yeah.
So I would perform a rectal exam. And is it an entire male? Sorry.
Oh, I didn't mention that, but no, it's not.
So I'd perform a rectal exam. So primarily feeling for the prostatic urethra if that's causing obstruction, and for pain, and pain and size of prostate and symmetry, and if you can get urine, I would do urinalysis. But if he's completely obstructed, unwilling to go, I would probably jump to imaging next. If he's emergent, it depends on the case. If he was emergent, if he was an emergency, like evidence of urethral obstruction, then I would catheterize him and stabilize him. But I'm assuming not for this medical case, so I would probably do imaging first. I would do an abdominal ultrasound to look at the urinary system, particularly the urinary bladder and the prostate. So evidence of obstruction would be an obstructive, to rule out a mechanical outflow obstruction. So a urolith, a mass that could be neoplastic or non-neoplastic of the bladder or the prostate. I would take some radiographs to look for post-pelvic urethra, so ensuring the entire penis and urethra were in the radiograph to look for uroliths. If you have probably the most radiolucent urolith, like a cystine urolith, in theory that could not show up, so you could do a contrast radiograph as well. And I would
Oh, we lost her. I was really into that story. So I think she was probably going to say that she would potentially do a double contrast because that's what we usually do in these cases on the road. So we often inject air into the bladder and urethra because sometimes, so we inject positive contrast and it coats the stones, and then we inject air and it provides this really nice negative contrast against the positive contrast. Same thing with masses with like irregular mucosal surfaces. The contrast sticks on the surface really well. So it's a really nice, it's so easy to do. And I sort of say to people, why don't you do a contrast urethrogram on the phone? And they're like, whoa, like literally just shove 10 mils of contrast up the urethra, just do it and do an x-ray. So it's really not a tricky thing to do. It is a little bit tricky to interpret because the urethra distends like not necessarily uniformly. And I always try and snap the radiograph right as I'm injecting. So there's kind of positive pressure and it's as dilated as it can get. So you get that little bit of kind of space around it. One thing that Helen mentioned doing the rectal, which is a great point, something clinically which is really handy is you can actually feel the pelvic urethra quite well on your rectal. So if there's a stone in there, you can literally, the dog will jump through the roof if there's a stone in that part of the urethra. And it's the hardest part to image either ultrasound or x-rays because it's surrounded by bone. So I always just run, as I'm doing my rectal, as I'm pulling my finger out, just straight underneath the rectum, completely ventrally. If you can kind of feel the urethra if you roll your finger side to side, and I just run it along the length there. So any mass lesions or stones stuck in that section, I'm pretty confident that I've felt it or that we need to image that area in more detail.
If you're more suspicious of a mass versus a urolith, would you prefer or give priority to BRAF versus doing your double contrast?
So the turnaround time for BRAF is like 6 weeks, 3 to 6
Oh,
weeks.
no.
It's not very practical because they present clinical most of the time, these patients. They present obstructed. You can't wait. So there's this kind of, I guess, it's not a rumor, it's very good science, but transitional cell carcinomas exfoliate really well, which means that they're quite diagnostic cytologically. Like the cytology is usually we get a lot of cells. But also when you do an FNA from externally, you drag neoplastic cells up through your needle track and you can seed neoplasia into areas where your needle's been. That's not a problem for us, I don't think. Like if I saw a mass at the absolute tip of the bladder, you could just go in and snip it out surgically and it would be curative, then I'm not going to stick a needle in that and risk a met. But most of these patients, we're seeing them when the mass is already causing obstruction. It's not surgically excisable. And there's absolutely no chance that the cells that I metastasize are going to catch up with the dog before the primary. So given that we can get a diagnosis that way, that's usually my preference rather than BRAF. So you will hear from a lot of specialists that you shouldn't FNA TCCs, but the logic behind that I think is flawed for me in like just practical sense kind of thing. Yes, I would palpate the urethra. If there was a mass there on our imaging, I would probably say FNA is an option if the mass isn't surgical, although traumatic catheterization and cytology in the urine are also options. Tell me about the BRAF test other than the turnaround time. What are we testing for? How sensitive is it?
Am I answering that? Oh, Helen, where's Helen?
Sorry, I'm back. I went in a signal black hole, sorry.
No, you're right, no worries. Do you want to answer, tell me about the BRAF test?
So it's looking for a genetic mutation that's expressed in urothelial transitional cell carcinomas. I think it's about 85 to 90% sensitive and about 95 to 99% specific. So it's really specific.
Yeah. So there's nothing else that causes that particular genetic mutation. So where I think the BRAF test is really nicely applied is if I've done an ultrasound and I've seen a polypoid thickening of the bladder wall. and the patient's had a history of cystitis. I'm like, it's very reasonable for this dog to have grown a polyp. I'm going to just do this test. It's not causing any clinical signs at the moment, but I would like to just rule that in or out TCC and then know whether I need to keep an eye on it quite acutely or not. Or whether you could do potentially then a curative surgery if you've seen it kind of as an incidental finding. So that's where I use the BRAF test. I rarely am in a clinical situation where I think it's reasonable to wait 6 weeks for a result. I normally am sending off cytology and all the other tests. All right, so that would be my genitourinary question if I was an examiner, because then you can cover onco and genitourinary. I would probably want you to mention biochem and renal value elevations and electrolyte derangements as a result of urinary obstruction. But Helen did sort of mention if this was an emergent case, I would manage it differently from if it was a more chronic kind of presenting case. And then what management options are there for transitional cell carcinomas?
You can put the patient on non-steroidals, which historically was piroxicam, but there is an evidence base that meloxicam or firocoxib are just as effective, and maybe because they're more cox selective, maybe better tolerated. You could do non-steroidals plus chemotherapy. I don't think there's consensus amongst oncologists which chemotherapy protocol works around. I think they essentially cycle through like doxorubicin, mitoxantrone, carboplatin. You can essentially cycle through them until one stops working. So you could put them on a Q3-week protocol after consultation with an oncologist. Or if some of them may be surgically resectable, but if not, you could refer them for stenting, which even though you're not resecting the tumor, would massively improve patient quality of life and comfort by just allowing urination. So it increases survival times, not because it's removing the tumor, but because you're increasing the time to euthanasia because of poor quality of life from not being able to urinate.
Yeah, excellent. So the stats on that is that stenting increases life expectancy by at least 12 months in most patients. So it's actually a really effective treatment. Like if you sort of think like they're in hospital for a day, they're out the same day, bloody expensive, but it's actually cheaper than a chemo protocol, and it extends life for longer than the chemo protocol would. Like average survival with an obstructed dog presenting for chemo is 6 months. With chemo. So yeah, it's quite an effective treatment, even though you kind of think, well, it's not actually doing anything for the cancer, but the combination of non-steroidals and a stent is a very reasonable combination if the owners can stretch to that in a like one-off kind of cash setting. And then add chemo to that, even better. Cool. And then the other thing that we haven't really been examined on is GIT. I think it's a bit hard to examine in an oral exam. And the only thing I think we would really work would be like showing up blood tests and doing a PLE case. That's the only thing I can kind of, that jumps into my head. Can anyone think of any other kind of examinable way of looking at GIT disease in an oral setting?
Couldn't you just have a diarrhea case?
Yeah, I
Don't you?
guess so.
I think like
Always Addisonian though.
yeah. Oh well, no. I had a very interesting case, and I think Jill Madison delivered it as a lecture once, and it ended up being tricurious, but everyone falls for the trap of hyponatremia being medicines.
So you've actually seen one of them?
I haven't.
Oh, right. Oh,
As in, it's been given as a case to work through.
I don't know if that actually happened. I once had a patient, I was sure that's what was going on. And I did the ultrasound, I'm like, I can see a worm in its guts. Like, I was so convinced. And it just kept coming back negative on its fecal floats. Damn it. And we
But I
treated it.
thought
And it didn't get better.
Trigerous often comes negative.
Yeah, I know, but we treated it and it didn't get better. Sorry, I've got a visitor. Hey.
I'm ready to go to school, but I feel really sick.
Don't go to school. Stay home. Stay home.
Are you right?
Yeah, I'm home. Yeah, it's all right. Thank you.
Oh.
I'm just finishing up. We're dancing. Okay.
Do
Sorry.
you need to go? You can, because if he's, do you need to go?
I'll go. I will go. One more minute. So I think that's a good, like, if someone flashed up a blood test result with hyponatremia, hypochloremia, hyperkalemia, and maybe even like a low protein level, just to throw everything on the paper and get you to assess those things, I think that would be probably fair game. And I would want my candidate to mention a trichuris infection and the fact that fecal floats are often negative. So there are little elements of questions in there, but then probably say Addison's would be much more likely, because that just doesn't happen. I'm saying this, I'm working in a very privileged area where there's not a whole heap of worms. Like preventative medicine is very well followed. So I'm sure it does happen in other areas, but not to me. Yeah. So, protein losing enteropathy. Next, so the next one is literally like, I think some people are even doing their oral exam that day, the next tutorial we have.
Okay.
So
No, it will be they start on they're the 28th, 29th, 30th, I think.
Okay, so we're gonna get another one in. So where I like the last few years I've done like this is what a oral exam looks like, and we talk about like we do run through questions. But we only ever get through like 3 questions in the hour, and we don't cover that much of a breadth. So would you rather do a practice exam where it's like structured like a normal exam, or would you rather just I throw a breadth of questions at you so you get to kind of revise a wider range of topics?
I feel like doing it like the real thing might be helpful, but I don't know what other people would think.
Okay.
I see what you mean. It's not as many topics, but I think structuring it so that we know what to expect would be helpful.
Yes. And should I try and bring my blank face so that I don't
I think it'll be very hard for you to do that.
I'll pretend I'm an examiner.
I volunteered this year to be an observer, and then I'm now rethinking it because I'm like, oh, I don't know how to hide my emotions. I think I should write to them. Sorry.
Just put a mask on, just in case.
Put a mask on. That's a good idea.
Yeah.
Yes, we may
Yeah.
do that.
Yeah.
Because I'll be like,
I'm a terrible examiner. I like want to hold their hand.
So in your experience, is it worth us reviewing like very basic cytology? Do you think that would come up as a cytological slide?
I think reviewing cytology is like a weeks and weeks and weeks long process because there's so many things that you could potentially review. I think that the investment that you'd make to feel confident looking at cytology is not worth the effort.
Okay.
It's very unlikely they're going to show a cytology slide, and if they do, it's going to be something like a crypto or a toxic neutrophil or something that you've seen that you'll recognize. And it also won't be a whole question on that. That will be like 1 mark.
Yeah.
So I would say absolutely no. Don't put any effort into it.
Okay, that makes sense.
Good. Oh, it's going to be a mast cell or something like that. All right, I better go. Thanks, guys.
thank you. Have a good day.
Bye.
Bye.
See ya.